Ladies and gentlemen, my name is Joanna Kacperczyk-Bartnik, and today, together with Aleksandra Strojna, we have an honor to interview the ESGO President, Professor Anna Fagotti, and past ESGO President, Professor Nicole Concin, on the topics regarding endometrial cancer. So we will discuss two different sessions, one about challenges in the current management of endometrial cancer with the emphasis on molecular profiling, and we will discuss whether genomics can have the impact on surgical treatment of patients with endometrial cancer. So, Professor Concin, could you please share with us what are the key messages from your presentation?
So our session, the overall session, focuses on molecular markers from the pathology point of view, from the FIGO point of view, the new FIGO classification, and also for treatment relevance. The molecular knowledge on this disease has changed our complete perception of endometrial cancer. It is not one disease, it is at least 4 different diseases. The histological subtypes have different prevalences of these molecular changes, and what we learned is that particularly in the high-grade histologies, the molecular classification really helps us to overcome issues that we face with histology and grading only. So these markers are highly prognostic and help us to better prognosticate our patients. And this is the reason why we have implemented them into guidelines, all 4 major European guidelines, societies, the ESGO, the ESTRO, the ESP, and the ESMO. And now also, as FIGO is from its nature a prognostic classification system, we have implemented into FIGO. Important to say and to stress is that this is optional. So there is one option for the new FIGO without access to mole marker. You can still stage your patients, and the option with molecular markers that if you include it, it will increase the prognostic precision of the system. Of course, there are treatment implementations already. We had treatment implementations in the guidelines of all 4 societies already in the adjuvant treatment setting for very specific clinical situations. And now this will change because last year we have seen first level 1 evidence data for the predictive value of mismatch repair deficiency and IO treatment. So we are revising the guidelines, and for the metastatic advanced stage cases there will be recommendations also based on molecular profiling for IO treatment, current approvals in place.
Amazing. I have a question, Professor Fagotti. Should we adapt surgical management according to genetic findings?
This is a very important and interesting question, and actually we all would love to do it, but we are not yet there. Indeed, we know that this molecular classification helps into stratifications in terms of prognostic factors, but actually no data are available up to now on the possibility to reduce the extent of surgery according to molecular stratification. Now, we are suggesting in the new guidelines upcoming that this kind of stratification should be done in the endometrial biopsy and not in the entire uterus if possible. And the reason is that the management of the tissue when the biopsy is smaller, the formalin fixed procedure is much easier, and so this will lead to less problem in terms of evaluation. But however, although we have the information preoperatively, we are not allowed to use it in order to tailor surgery. And I want to tell you exactly what we mean for tailoring. It means lymph nodal staging, for example, extensive if in the case we do not have any detection with ICG, or peritoneal staging, for example, for other kinds of tumors. So we are still here with the classical treatment for the classical surgical treatment for endometrial cancer patients.
Amazing. Thank you very much. Thank you for this interview, for highlighting your sessions, and congratulations for this amazing FIGO staging on molecular endometrial cancer.
Thank you very much.